Okay, so let's try and unpack this. Imagine, imagine a moment that just fundamentally shifts your entire world. It's not like, a simple repair job fixing a broken part. No, it feels more like a deep betrayal, doesn't it? A disease that's somehow become, well, part of you. The source material we're really digging into today, it captures this so powerfully. It describes a cancer diagnosis as a traumatic and revolutionary event. It totally reshapes how you see yourself, your role in life. And there's this feeling, the text says, of being attacked and invaded by a disease that could be anywhere. Suddenly, every little ache, every minor thing, it takes on this desperate significance. It's just profoundly different from, say, heart disease, which, you might see as more like a malfunctioning part. With cancer, the source suggests the patient often feels that they, the person, are fundamentally diseased, like their own body has betrayed them somehow.
Yeah, that emotional, that psychological weight, it's just immense, isn't it? And the source material is absolutely right to put that front and center. Understanding that personal impact, that's really the foundation. It's the human context for all the complex clinical stuff we're about to get into.
And getting into that stuff, that's exactly our mission today. Welcome, everyone, to a deep dive into understanding the approach to the patient with cancer. We're going to immerse ourselves really deeply in a specific source, Chapter 69, from a core medical text, right in the oncology and hematology section. Our goal, to go into this material with such detail and nuance. Well, we want to reach a level of understanding that's really akin to the elite professionals in this field. We're here to genuinely master this chapter.
Absolutely. And we'll unpack everything this chapter throws at us, starting with the sheer scale of the problem, the numbers, the trends globally and nationally. Then we'll move through the really vital steps of patient management, diagnosis, staging.
Right, the practical steps.
Exactly. Then into the critical strategies for planning treatment, the absolutely indispensable role of supportive care, which is huge. And then finally, those incredibly important, very sensitive considerations around the end of life. By meticulously dissecting what's in this text, the aim is to build a really thorough, integrated understanding.
It's definitely a vast topic and often a difficult one, but as this chapter shows us, really grasping the approach that's essential to seeing the whole picture of cancer care.
Precisely. Because the approach, it isn't just about applying scientific facts in a vacuum. It's where all that intricate scientific knowledge, the biology, the stats, the treatments, it's where it all gets integrated within the context of that deeply personal human experience of, navigating a cancer diagnosis.
Okay, so let's start where the text does, really grappling with the sheer scale of this challenge. I mean, despite decades of research, incredible advances, cancer is still just a monumental health problem, isn't it? Globally and right here.
It truly is. And the chapter kicks off by pointing out a fundamental challenge actually right here in the U.S. There isn't one single unified nationwide cancer registry, which means the estimates we rely on for incidence, that's new cases and mortality deaths, they're not a direct count across the whole country. It's an estimation process.
Right. So how do they get those numbers then? The text explains it, involves combining data from a couple of key sources.
Exactly. It's primarily the National Cancer Institute's SEER database that stands for Surveillance, Epidemiology, and Results. Now, SEER collects really detailed data, but only from 13 specific geographic sites. That represents about maybe 10% of the U.S. population. So that data is then extrapolated using broader population data from the U.S. Census Bureau to get those national estimates.
I see. And when you look at those estimates, say for 2021 in the U.S., the picture they paint, it's pretty stark. The text puts the number of new invasive cancer cases at nearly 1.9 million.
Yeah, nearly 1.9 million. And breaking that down by sex, it was roughly 970,000 cases in men and about 928,000 in women.
And the numbers for mortality? Well, they're just as sobering, really. About 680,500 deaths attributed to cancer in that same year. Around 319,000 among men and 289,000 among women. These aren't just abstract statistics, are they? They represent a massive human impact.
Absolutely. And the text includes Table 69-1, which then drills down into these numbers by specific cancer site. And this is where it gets really interesting because you start to see critical differences between how common a cancer is versus how deadly it is, and differences between men and women. It's where the numbers start telling stories.
Okay, so let's look at incidence first of the new cases. According to that table, for men in 2021, which cancers were most common?
For men, the top site, it was prostate cancer making up.
Yeah.
A huge chunk, 26% of all new cases. Then you had lung cancer at 12%, colorectal at 8%, and bladder cancer at 7%.
26% for prostate, wow. And for women?
For women, breast cancer is overwhelmingly the most common diagnosis. It accounts for 30% of new cases. Lung cancer is next at 13%, then colorectal at 8%, and endometrial cancer of the uterine lining at 7%. So clearly, prostate and breast cancer are the most frequently diagnosed.
Okay, but then you look at the deaths for that same year, and the picture changes, sometimes dramatically. It really highlights how different the prognosis can be. So for men, what were the leading causes of cancer death?
For men, unfortunately, lung cancer takes the top spot, accounting for 22% of cancer deaths. Prostate, which was number 1 for incidence, is second here at 11%, then colorectal at 9%, and pancreatic cancer at 8%.
And for women, similar pattern with lung cancer.
Very similar. Lung cancer is also the leading cause of cancer death for women at 22%. Breast cancer, despite being 30% of diagnoses, accounts for 15% of deaths. Colorectal is next at 8%, and pancreatic cancer is also 8%.
So if you just pause on that for a second,
Yeah.
you see the difference. Prostate cancer, 26% of new cases in men, but only 11% of deaths. Breast cancer, 30% of new cases in women, 15% of deaths. But then you compare that to lung cancer, 12% of male cases, 22% of deaths. 13% of female cases, 22% of deaths. Or look at pancreatic cancer, only around 3% of new cases for both men and women, but responsible for 8% of deaths in both. That's a huge disparity.
This contrast is just a crucial insight from the text, right off the bat. It tells you something really fundamental about these diseases and, our ability to manage them effectively. Cancers like prostate and breast, while they're diagnosed very commonly, have relatively lower mortality percentages compared to how often they occur. And that often reflects the success of screening programs catching them earlier when they're more treatable, plus big advances in treatment over the years.
Makes sense.
But conversely, cancers like lung, and especially pancreatic cancer, despite having lower incidence numbers in that table, they account for a tragically much higher proportion of the deaths. Pancreatic cancer in particular just stands out. It's often diagnosed late, it's known to be highly aggressive, and it's proven really resistant to many current therapies. That leads to that high mortality rate relative to how often it's diagnosed.
That difference between how often you get it versus how likely you are to die from it, that's a really critical takeaway from these numbers.
It really is. And digging down even further, the text highlights another incredibly significant factor: age. It states it pretty unequivocally. Age is the single most significant risk factor for developing cancer overall. In fact, a really striking figure, fully two-thirds of all cancer cases occur in people over 65 years old. The text even gets specific, mentioning that incidence often increases dramatically with age, sometimes as the, third, fourth, or even fifth power of age, depending on the specific cancer site.
Wow. And the lifetime risk figures the chapter provides really drive that point home, don't they?
Yeah.
For the youngest group shown, birth through 49 years, the risk is 1 in 29 for men, 1 in 19 for women. Pretty low.
Relatively low, yeah.
But then you look at the oldest group, age 70 and older. The risk just explodes. It becomes 1 in 3 for men and 1 in 4 for women.
The cumulative effect over a lifetime is just starkly clear. It leads to those overall lifetime risks, the text quotes, 40.5% for men and 38.9% for women, essentially around 2 in 5 people. And this profound increase with age, well, it's thought to be due to a combination of things accumulating over time. You get more genetic mutations as your cells divide over decades, plus exposure to environmental factors, and also age-related changes in the immune system, making it maybe less effective at finding and eliminating those potentially cancerous cells.
Okay. The text then puts cancer in the broader context of why people die in the U.S. It's the second leading cause of death overall, right? Just behind heart disease.
Yes, but it's really important that the text acknowledges a major public health success story there. Deaths from heart disease have dropped massively by 45% since 1950, and they're still falling. That's a huge testament to prevention and treatment advances in cardiovascular health.
Which leads to this really significant milestone highlighted in the source. Cancer has actually overtaken heart disease as the #1 cause of death for people under the age of 85.
That's a profound shift. Now, turning our attention to trends over time, the source material uses some figures to illustrate both the progress we've made and, the ongoing battle. Figure 69:1 looks at incidence trends, and it shows that while cancer incidence overall was declining by about 2% per year, starting around 1992, it's actually been relatively steady since about 2013.
Okay, so incidence leveled off somewhat recently, but figure 69:2 tracks mortality trends, the death rates. And this is where you see a really major turning point, isn't it?
It really is. After something like 70 years where cancer death rates were unfortunately increasing, they began a significant decline starting right around 1990, 1991. The text gives specific figures for the period between 1990 and 2010, a 21% decrease in mortality among men, and a 12.3% decrease among women during those 2 decades.
That's substantial progress.
Yeah.
What does the text attribute this turnaround to?
Well, the source directly links these positive mortality trends since the early 90s to advances right across the board. Improvements in prevention efforts, reducing exposures, earlier and more accurate diagnosis thanks to screening and better technology, and significant progress in treatment options, chemo, radiation, surgery, targeted therapies. Fudge 69-4 in the text even tries to quantify the lives saved. It uses this concept of cancer deaths averted. Basically, comparing the actual death rates to what would have been projected based on earlier trends, it suggests that millions of cancer deaths have been prevented since that turning point in the early 1990s.
That feels like, well, a powerful validation of all the immense effort poured into cancer research and public health, even though the fight is obviously far from over.
Absolutely. The text also dives into survival rates. And again, you see clear progress, but it also shines a light on some concerning disparities. It cites a really significant improvement in the 5-year survival rate for white patients, climbing impressively from just 39% back in the 1960s up to 68% in the 2010s.
That's a big jump. But it's crucial that the text doesn't shy away from the racial differences, right? It states that cancers are more often deadly in blacks.
It does. It notes a lower 5-year survival rate of 63% for black patients in the 2010s compared to that 68% for white patients. Though importantly, it does mention that these racial differences seem to be narrowing over time, which is hopefully a positive sign.
And Table 69-3 gives even more detail on these variations across different racial and ethnic groups.
Yes, it provides specific examples that really underscore these differences. For instance, black men have both higher rates of getting prostate cancer and higher death rates from it compared to white men. Black and Hispanic women show higher rates of getting and dying from cervical cancer. Asian Pacific Islanders and American Indians have higher liver cancer incidence and mortality. It breaks it down quite clearly.
The text then makes a really significant comment about why these differences exist, stating the basis is unclear. That feels important.
It's a critical point. It highlights that while we can see the statistical disparities very clearly, the root causes are likely incredibly complex and multifactorial. It's probably a mix involving genetics, environmental exposures, socioeconomic factors, differences in access to healthcare, maybe quality of care, other systemic issues. It's much more than just the numbers themselves can tell us, and it points to areas needing much deeper investigation.
It definitely underscores that layer of complexity behind the statistics and the inequities in outcomes.
For sure. Now, stepping beyond just the U.S. picture, the source gives us a global perspective, using 2018 estimates from the Globocan database. Worldwide, the estimate was 17 million new cases and 9.5 million deaths. And importantly, the text notes that global cancer rates are actually increasing.
Increasing globally. And the distribution, shown in figure 69-5, isn't just proportional to population, is it?
Not at all. Asia has nearly 60% of the world's population, but accounted for about 45% of the cancer cases in this data. Europe, though, with less than 10% of the population, had a disproportionately high 26% of the cases. North America had 14.5%. Central South America and Africa had smaller shares of the global cases, 7.1% and 6% respectively, even though they have larger shares of the world population than Europe or North America.
That's interesting. And globally, lung cancer comes out on top.
Yes, lung cancer is cited as the most common cancer type and the leading cause of cancer death worldwide. But its incidence varies wildly. The text gives a range from a low of 2 per 100,000 for African women to a high of 61 per 100,000 for North American men. Huge variation.
Breast cancer is second most common globally.
Second most common for incidence, yes, but it ranks 4th in terms of deaths globally after lung, stomach, and liver cancer.
And there are these distinct differences mentioned between more and less developed countries in terms of which cancers are most prevalent.
Right. Lung, breast, prostate, and colorectal cancers are noted as being 2 to 3 times more common in the more developed regions.
Whereas other cancers are more common in less developed regions.
Exactly. Liver, cervical, and esophageal cancers are cited as being 2 to 3 times more common in less developed regions. Stomach cancer incidence is kind of similar overall globally, but shows dramatic regional variation, much more common in Asia, for example. And cervical, breast, and liver cancers are specifically listed as the most common types in Africa.
That regional variation is really striking. And the text then introduces this crucial point that kind of bridges these statistics to prevention, mentioning 9 specific modifiable risk factors.
Yes, this is powerful. It states that these 9 factors are estimated to be responsible for over a third of all cancers worldwide.
What are they?
Okay, they are smoking, alcohol consumption, obesity, physical inactivity, low fruit and vegetable consumption, unsafe sex linked to cancers like cervical and liver, air pollution, indoor smoke from household fuels, a big issue in some parts of the world, and contaminated injections, again, linked to certain infections that cause cancer.
That's a direct link from the global burden back to things that can potentially be changed through public health efforts and individual choices. It hints at why some cancers might be more common in certain regions too, right? Like maybe infections or environmental factors playing a bigger role in those higher rates of liver or cervical cancer in less developed countries.
Absolutely. It reinforces that the fight against cancer isn't just about treatment in the clinic. It starts much, much earlier with understanding and trying to mitigate these risks.
Okay, so once we've got a handle on the sheer scale of the problem, the landscape of the disease, the chapter then pivots. It moves into the critical steps involved when an individual patient actually comes in, possibly with cancer, and it starts, logically enough, with the initial evaluation.
Yes, and the text really emphasizes that every single part of that routine history and physical exam is crucial for gathering vital information. It's not just zeroing in on the potential tumor, it's about understanding the whole patient context.
So what specific kinds of information is the physician really looking for during that initial history taking?
Well, they're definitely focused on the duration of symptoms. Is this something new or has it been going on for a while? That can give clues. Past medical history is absolutely vital because any existing health conditions or previous treatments can significantly impact what cancer therapies might be possible or influence the risk of side effects.
And the social history is key too, I imagine.
Absolutely. This is where you might pick up on potential occupational exposures to carcinogens or habits like smoking and alcohol use. These aren't just major risk factors. They can also affect how well someone tolerates treatment and influence outcomes. Family history is also probed really carefully. You're looking for any patterns that might suggest a familial predisposition to certain cancers. That could lead to genetic counseling, maybe increased surveillance, or even preventive strategies for the patient and potentially their relatives too.
And the review of systems. That sounds like it's casting a really wide net looking for subtle signs.
It is. It's an active search for any early symptoms that might hint at metastatic disease, meaning the cancer has already spread from where it started, or perhaps signs of paraneoplastic syndromes. Now, paraneoplastic syndromes are fascinating, often complex conditions. They happen when the tumor itself produces substances like hormones or cytokines that cause symptoms elsewhere in the body, often mimicking other medical conditions entirely. Identifying these is all part of assembling that complete clinical picture. It really is like the initial detective work phase in oncology.
Okay, so this comprehensive initial assessment then guides the whole diagnostic process, and the text is very clear about what that process relies on most heavily.
It states it pretty directly. Diagnosis relies most heavily on invasive tissue biopsy. While things like imaging scans can strongly suggest cancer, getting a definitive diagnosis almost always requires getting an actual sample of the suspicious tissue.
And the text explains why that biopsy is so absolutely critical. It goes way beyond just confirming, yes, it's cancer.
Exactly. The biopsy allows for a really careful evaluation of several critical characteristics of that specific tumor. You get the histology, what the cells actually look like under the microscope. You get the grade, how aggressive or abnormal the cells appear. You assess invasiveness, is it breaking through tissue boundaries? And increasingly, you get vital molecular diagnostic information. This can include identifying specific markers on the cell surface, proteins inside the cells, or particular molecular signatures like chromosomal translocations. The text even mentions the specific T814 translocation, often seen in Burkitt's lymphoma, or patterns of gene expression that we know are linked to prognosis, or can predict how well a tumor might respond to specific targeted therapies.
So the biopsy isn't just a yes-no. It provides this wealth of information needed to really understand the specific nature of that particular patient's cancer, essential for planning treatment.
Precisely. The text does mention some exceptions, like maybe using fine needle aspiration for thyroid nodules, but the general principle holds. You usually need an adequate tissue sample for this detailed analysis.
And it addresses that challenging scenario. A patient shows up with clear signs of metastatic disease, cancer spread, but it's not immediately obvious where the cancer actually started the primary site.
Yeah, that happens. And the text outlines a systematic approach to try and pin down that primary site. It involves considering the patient's age and sex, looking at exactly where the metastases are located, carefully examining the histology of the metastatic tumor sample itself, and checking for specific tumor markers in the blood or tissue. They also review the patient's full medical history again for any clues. And the text specifically notes that in this tricky situation, attention often initially focuses on ruling out lung cancer, just because it's such a common source of metastasis.
Okay. So once that diagnosis is confirmed, and the patient has been given that incredibly difficult news, the text strongly advocates for a multidisciplinary approach to managing their care from that point on.
This is presented as really the best practice standard. It emphasizes that cancer management is best undertaken by a whole team involving multiple different specialties. It's not just a suggestion. It's highlighted as pretty crucial for navigating the complexity that follows a diagnosis.
What kind of professionals make up this team, according to the text?
Well, the text lists the core players. The primary care physician, medical oncologists, they're the ones managing chemotherapy, targeted therapies, immunotherapy. Then surgical oncologists who perform the cancer surgeries, and radiation oncologists who administer radiation therapy. But the team extends far beyond just the physicians. It includes oncology nurses, pharmacists, social workers, rehabilitation specialists, maybe nutritionists, pathologists, radiologists, the list goes on. The key thing isn't just having these people available, but that they must work closely with each other, and just as importantly, with the patient and their family.
That collaboration sounds absolutely essential, especially when you think about coordinating treatments that might involve surgery, then chemo, then radiation.
Exactly. So, after the diagnosis and getting that team involved, the text says the very first priority is determining the extent of the disease. This is all about defining the prognosis and involves the process we call staging.
Staging. Okay. So this is fundamentally about figuring out how much cancer there is and where it is in the body.
That's the core of it. And the principle the text reinforces is simple but absolutely critical. Curability is generally inversely proportional to tumor burden. In simpler terms, the less cancer there is and the more localized it is, the higher the likelihood of successful treatment and cure.
So the ideal scenario then is catching cancer really early, maybe before it even causes symptoms, or through a screening test. The text says a very high proportion of those patients can be cured.
That's the ideal. Unfortunately, more often, patients present because they have symptoms. Maybe it's the physical mass effect the tumor is pressing on something, or maybe it's symptoms caused by substances like cytokines or hormones that the tumor is producing. Staging is the systematic process of using various tests, some non-invasive like scans, some invasive like biopsies, to evaluate the precise extent of the disease in these patients.
The text distinguishes between two main types of staging. Let's start with clinical staging. What's that based on?
Clinical staging, or CTNM, is based on all the information you can gather before any major surgery. So this includes the findings from the physical exam, results from standard x-rays, isotopic scans like bone scans, CT scans, PET scans, MRIs, other imaging techniques. It's the picture you have before operating.
Okay. And then there's pathologic staging.
Well, pathologic staging, or PTNM, adds information obtained during surgery. This could be what the surgeon feels or sees directly, maybe intraoperative palpation of organs or tissues. It includes the removal and examination of regional lymph nodes or biopsies taken from organs or areas where spread is suspected. Pathologic staging absolutely requires the histological examination, looking under the microscope of all the tissues that are surgically removed. This surgical procedure could be a relatively minor one focused just on staging, like a sentinel lymph node biopsy, or it could happen as part of the main definitive surgery to remove the primary tumor itself.
And the text makes a note about a specific prefix that's used sometimes.
Right. That Y prefix, like in UPTNM, is used specifically when staging is done after the patient has received neoadjuvant therapy. Neoadjuvant therapy is treatment maybe chemotherapy or radiation, or both given before the main surgery. The idea is often to shrink the tumor first, so the YAPTN stage reflects the extent of disease found pathologically after that initial treatment has already happened. This is quite relevant for certain locally advanced cancers, like some breast or head and neck cancers.
And the value of staging, both clinical and pathological, it's huge, right? It's not just assigning a label.
No, absolutely not. It's the primary determinant used to select the most appropriate treatment options for that patient. And it's also fundamental for giving the patient a prognosis and estimate of their likely outcome. It guides everything that comes next.
The most widely used system for staging solid tumors, the one the text really focuses on, is the TNM system. Can you break that down?
Sure, TNM is a standardized system based on anatomy. The T stands for tumor. It describes the size and/or the extent of invasion of the primary tumor itself. It's typically graded on a scale, often T1 to T4, where higher numbers generally mean a larger or more invasive primary tumor. The exact criteria depend on the specific cancer type.
Okay, T for tumor. Then N is for node.
Correct. N indicates the involvement of nearby or regional lymph nodes. It's usually designated as N0 if no regional lymph nodes contain cancer. Then N1, N2, or N3 indicate increasing degrees or extent of nodal spread. Again, the specifics vary quite a bit depending on the location and type of cancer.
And M stands for metastasis. This sounds like the really critical one for many cancers.
It often is. M refers to the presence or absence of distant metastasis, meaning the cancer has spread to sites far away from the primary tumor and its regional lymph nodes. M0 means no distant metastases are detected. M1 means distant metastases are present.
So these individual T, N, and M scores, and sometimes the tumor grade, G, how aggressive the cells look they get, combine somehow into an overall stage, usually those Roman numerals, I through V.
That's exactly right. They're grouped into stage categories, typically stage 1, 2, 3, and 4. And the text reinforces that core principle again. As you move up from stage I towards stage 4, the overall tumor burden generally increases, and unfortunately the likelihood of cure decreases significantly. Stage 4, by definition, presence of M1 disease, generally indicates metastatic cancer that is often not curable, though treatable.
And the text mentions that while TNM is super common for solid tumors, there are other systems used for specific cancers.
Yes, it briefly notes other anatomic staging systems, like the Duke system historically used for colorectal cancer, the FIGO system for gynecologic cancers, and the Ann Arbor system, which is specifically used for Hodgkin's lymphoma.
And it also points out that blood cancers, hematopoietic tumors like leukemia, myeloma, lymphoma, they're often exceptions to these solid tumor staging rules.
Right, because these cancers are often already widespread or disseminated throughout the body or bone marrow at the time of diagnosis, they don't necessarily spread in that same stepwise, localized way that many solid tumors do. So for these types of cancers, other factors besides just anatomy, like specific blood counts, genetic markers, or burden of disease markers, are typically used to determine prognosis and guide treatment rather than a classic TNM stage.
Okay. Now, beyond the anatomical extent of the tumor captured by staging, the text identifies a second major factor that determines a patient's outcome. That's their physiologic reserve.
This is really about the patient's overall health status, their fitness, their ability to withstand both the disease itself and the treatments we use. The text makes the point very clearly. A patient who is, say, already bedridden before their cancer diagnosis is likely to fare worse, even if they technically have the same stage of cancer as someone who is fully active and healthy otherwise.
So why is this physiologic reserve so important?
Well, it's crucial because it indicates the patient's capacity to cope with the immense physical stress imposed by the cancer, and maybe even more importantly, the considerable stress and toxicity that comes with cancer treatments like major surgery, chemotherapy, or radiation therapy. Directly measuring this reserve is difficult, so the text explains that clinicians rely on surrogate markers, things we can measure or assess that reflect the patient's overall condition.
We already talked about age being the biggest risk factor for getting cancer, and the text says it also serves as a kind of surrogate marker for declining physiologic reserve, right?
Exactly. Generally, older patients may have less reserve than younger patients, although age alone isn't the whole story. And then there are these performance status scales. These are really practical, widely used clinical tools designed to quantify a patient's functional ability. The text details two main ones: the Karnofsky Performance Status, or KPS, and the ECOG Performance Status. ECOG stands for Eastern Cooperative Oncology Group.
Okay, let's look at Karnofsky first. Table 69-4 lays it out. It goes from 100, which is normal, no complaints, no evidence of disease, all the way down to 0, which is dead. What are some key points on that scale?
Well, a score of 70 on the Karnofsky scale means the patient is able to care for themselves, but they're unable to carry on normal activity or do active work. A score of 50 means they require considerable assistance and frequent medical care. The text explicitly states that a Karnofsky score of less than 70 generally indicates a poor prognosis unless the underlying reason for that poor performance status is potentially reversible, like maybe an infection that can be treated or a symptom that can be controlled.
And the ECOG scale, table 69-5 shows that one. It ranges from 0 to 5.
Right. ECOG 0 means the patient is fully active, able to carry on all their pre-disease activities without restriction. ECOG 1 means they're restricted in physically strenuous activity, but they're ambulatory and able to do light work. ECOG 2 means they're ambulatory and capable of all self-care, but they're unable to carry out any work activities. Importantly, they're up and about more than 50% of their waking hours. Then you get to ECOG 3, which means they're capable of only limited self-care, and they're confined to bed or a chair more than 50% of their waking hours. ECOG 4 means they're completely disabled, cannot carry on any self-care, and are totally confined to bed or chair. And ECOG 5 is dead.
Similar to Karnofsky, the text notes that an ECOG score of 3 or greater generally indicates a poor prognosis. Again, unless the cause of that poor performance status is potentially reversible.
So when you look at these performance scales, you can really see how they're trying to capture the patient's overall ability to cope, their functional status, which is distinct from just how much tumor they have. Exactly. There are practical, real-world measures used every day in oncology clinics to help gauge how well a patient might tolerate potentially aggressive therapy, to help guide treatment decisions, and also to provide important prognostic information alongside the stage.
Okay, so we have stage, tumor burden, and performance status, physiologic reserve. The text then identifies a third critical determinant of prognosis: the biologic features of the tumor itself.
Yes, and this is an area that's just exploding in importance and complexity. More and more, we understand that a patient's prognosis, and especially how well their cancer is likely to respond to specific treatments, is intimately linked to the underlying molecular and genetic characteristics of the tumor cells.
What specific kinds of biologic factors does the text mention as being important?
It lists several categories, things like the expression levels of specific oncogenes. Those are genes that can drive cancer growth when activated. Also, genes related to drug resistance, genes involved in apoptosis or programmed cell death. If tumors can evade apoptosis, they can grow uncontrolled. Genes related to the ability to metastasize. It also mentions specific cytogenetic abnormalities, changes in the structure or number of chromosomes within the cancer cells, and things related to how fast the tumor is growing, its growth fraction, which can be estimated using proliferation-related markers like PCNA, proliferating cell nuclear antigen. The text notes that tumors with higher growth fractions tend to behave more aggressively.
This is so fascinating because it means, as the text points out, that even if two tumors look basically identical under a standard microscope, same histology, their fundamental biology could be vastly different, and that could lead to completely different outcomes or responses to treatment.
Exactly. The text really drives this home by stressing the enormous heterogeneity that can exist, not just between different patients' tumors, but even within a single patient's tumor. You can have different populations of cells with different molecular profiles inside the same tumor mass. And conversely, sometimes tumors that look morphologically quite different might actually respond similarly to a specific targeted therapy if they happen to share the same underlying molecular driver that the therapy targets. This biological complexity is why molecular profiling of tumors is becoming so incredibly crucial in modern oncology.
And the text adds one more layer: the patient's own host genes can play a role too.
Yes, specifically mentioning host genes involved in drug metabolism. Variations in these genes' pharmacogenomics can influence how quickly or slowly an individual patient processes certain chemotherapy drugs. This, in turn, can affect both the drug's safety profile, their risk of experiencing toxicity, and potentially its efficacy as well. It adds yet another layer of potential personalization to treatment planning. #tag making a treatment plan and supportive care.
Okay, so we've got the diagnosis, we understand the extent of the disease through staging, we've assessed the patient's overall health using performance status, and we have some idea about the tumor's specific biology. Now, the multidisciplinary team, working closely with the patient and their family, needs to actually formulate a treatment plan. The text says the very first decision, and it's a fundamental one, is about the intent of that treatment.
That's absolutely right. The initial crucial decision is whether the primary goal, the intent of the treatment, is going to be curative, meaning the aim is for complete eradication of the cancer, a cure, or if the intent is palliative. Palliative intent comes into play when cure isn't considered a realistic goal. In that case, the focus shifts to controlling the disease as much as possible, managing symptoms effectively, improving or maintaining quality of life, and potentially extending life, but without the expectation of eliminating the cancer entirely. And this critical decision, the text emphasizes, is based on integrating all those factors we just discussed: the stage of the disease, the likely prognosis based on performance status and tumor biology, and crucially, the patient's own values, priorities, and wishes.
And this is where that multidisciplinary collaboration you mentioned earlier becomes absolutely vital again.
Essential. The text really emphasizes the need for close cooperation and communication among all the team members, the medical, surgical, and radiation oncologists, the nurses, everyone involved to decide on the optimal treatment modalities, and importantly, the right sequencing of those modalities.
The text specifically mentions neoadjuvant therapy, again, here in the context of planning.
Yes. It highlights neoadjuvant therapy that's giving chemo or chemo plus radiation before the definitive surgery as a strategy that can potentially improve outcomes for patients with certain types of locally advanced cancers. It mentions breast and head and neck cancers as examples where shrinking the tumor first might make surgery more effective or less extensive.
And for treatment plans that involve multiple types of treatment, like maybe chemotherapy, then surgery, then radiation, the text stresses the absolute need for careful coordination.
For sure. Whether these different treatments are given sequentially, one after the other, or concurrently at the same time, effective coordination among the relevant specialists is highlighted as just indispensable. It's needed to maximize the chances of success and also to manage the potential combined toxicities. The text also notes that surgery's place in the sequence isn't fixed. Sometimes it comes first, sometimes it follows other treatments, depending entirely on the specific cancer, its stage, and the overall plan.
Now, the text makes a very strong, almost emphatic point about the treatment plan itself once it's decided. What was that?
It's a really important point about adherence to evidence. It states quite firmly that the treatment plan should precisely follow a standard protocol that has been proven effective through rigorous clinical trials, or, alternatively, the treatment should be delivered as part of a formal clinical research protocol, a clinical trial, and it includes a pretty stern warning. Ad hoc modifications of standard protocols are likely to compromise treatment results. This strongly underscores the importance of evidence-based medicine in oncology. You stick to the regimens that have been validated through careful research.
That warning really hits home. It highlights that oncology isn't really a field for just making things up as you go along.
Not at all. It demands adherence to established protocols that have been developed based on data from often large numbers of patients. The source also notes, helpfully, that access to these standard protocols and information about ongoing approved clinical research studies is now widely available electronically, mentioning resources like the National Cancer Institute's CancerNet PDQ database online.
Okay. Now, shifting gears slightly from curative strategies, the text dedicates some important space to palliative care. It focuses on the physician's essential role when cure is no longer the goal. And it seems to actively push back against any potential feelings clinicians might have, like guilt or frustration, that could lead them to spend less time with patients receiving palliative care.
It does address that potential dynamic, yes, and it offers a profoundly human reminder about what constitutes comfort in this context. It says, comfort is provided by holding the patient's hand, continuing regular examinations, and taking time to talk. It's not always about high-tech medical interventions. Sometimes it's about presence and connection.
That flows really naturally into the broader discussion of supportive care, which the text identifies as absolutely essential for success. The statement is really clear and powerful. Success of cancer therapy depends on the success of the supportive care.
And the rationale given in the text is basically twofold. First, patients who are suffering from uncontrolled symptoms think severe pain or debilitating nausea and vomiting. They might simply be unable or unwilling to continue with potentially curative therapy. If you can't manage the side effects, you might undermine the main treatment goals. Second, supportive care is presented as a major determinant of the patient's quality of life, and that applies whether they're undergoing curative treatment or receiving purely palliative care. And interestingly, the text even points out that well-organized palliative and supportive care has actually been shown to be cost-effective in the long run.
The source offers a kind of guiding principle, almost a credo for oncology practice.
Yes, it's a well-known one. To cure sometimes, to extend life often, and to comfort always.
That really seems to capture the layered goals in cancer care beautifully, doesn't it? Cure is the ideal, but not always possible. Extending meaningful life is often achievable. But comfort and support, those are universal goals that should apply to absolutely every patient, regardless of their prognosis.
Couldn't agree more. Now, the text then gets into the specifics of managing the complications that inevitably arise, both from the cancer itself and from its often toxic treatments. It acknowledges right up front that cancer therapies are toxic.
It's just a reality of the field?
It is, and managing that toxicity is a huge part of supportive care. The text notes an important distinction. While some temporary decline in functional status due to side effects might be considered acceptable during treatment given with curative intent, treatment-induced toxicity is generally less acceptable when the goal is palliation, where quality of life is paramount. Common side effects listed include things like nausea and vomiting, febrile neutropenia, that's developing a fever when your white blood cell count is dangerously low due to chemo, and myelosuppression, which is the suppression of bone marrow function affecting the production of all blood cells. The text does state, perhaps optimistically, that tools exist to minimize much of the acute toxicity.
Now, there's a really crucial rule of thumb the text offers here for how clinicians should interpret new symptoms that pop up during treatment. This seems really important.
It's incredibly important, mainly to prevent misinterpretation or, giving up hope too early. The rule, as stated, is any new symptoms that develop while a patient is undergoing treatment should always be assumed to be reversible until definitively proven otherwise.
Always assume reversible first. Can you give some of the examples the text uses to illustrate this?
Yes, it gives several good ones. For instance, if a patient develops anorexia, weight loss, or jaundice, it could be due to reversible conditions like cholecystitis, inflammation of the gallbladder, rather than automatically assuming it's the tumor progressing to involve the liver or surrounding structures. Another example, intestinal obstruction. While it could certainly be due to tumor growth, it might also be caused by reversible adhesions from a previous surgery. Even central nervous system, CNS, symptoms, things like confusion or weakness, which one might immediately fear represent brain metastases or a paraneoplastic syndrome, could potentially just be side effects of medications the patient is taking. The text really stresses the necessity of pursuing a definitive diagnosis for any new symptom, even if it means doing another biopsy, to avoid just fatalistically assuming it's incurable progression when it might be something treatable.
That rule definitely requires discipline, not immediately jumping to the worst possible conclusion.
Absolutely. It underscores the importance of thorough investigation and maintaining hope for finding reversible causes whenever possible.
Okay. The text also includes a detailed section, which seems critical, on how response to treatment is actually assessed. How do you know if the plan is working?
Right, this is fundamental. Beyond just noting changes in physical exam findings, which should be recorded systematically, maybe in a flowchart, assessment primarily involves repeating the specific imaging tests, like CT scans or PET scans that initially showed abnormal tumor sites during the staging process.
So if the staging scan showed a lesion somewhere, you repeat that same scan after a certain amount of treatment. What if the repeat scan looks completely normal?
This is an important point in the text. If the imaging appears to normalize at a site that was previously involved with tire, a repeat biopsy of that specific site is technically required to truly document a complete response by pathologic criteria proving microscopically that the cancer cells are gone. However, if visible residual disease still remains on the imaging scan after treatment, a biopsy usually isn't necessary just to assess the response. You can often measure the remaining disease directly on the scan.
And the text provides these very precise, standardized definitions for the different response categories, doesn't it? Used in clinical trials and practice.
Yes, these are crucial for consistency. A complete response, CR, means the disappearance of all evidence of disease, no detectable cancer left. A partial response, PR, is defined as a significant reduction in tumor size. Specifically, the text mentions the older criteria of greater than a 50% reduction in the sum of the products of the perpendicular diameters of measurable lesions. It also mentions the more widely adopted RECIST criteria response evaluation criteria in solid tumors, where a PR is typically defined as at least a 30% decrease in the sum of the longest diameters of target lesions.
Okay, CR is gone. PR is significant shrinkage. What if the cancer isn't shrinking significantly or worse?
Progressive disease, PD, is defined either by the appearance of any new cancerous lesions or by a significant increase in the size of existing lesions. Using the older criteria, that was greater than a 25% increase. Using RECIST, it's typically defined as at least a 20% increase in the sum of diameters of target lesions, or the appearance of new lesions. Anything that doesn't meet the criteria for CR, PR, or PD falls into the category of stable disease, SD. The cancer is still there, but it hasn't shrunk enough to be a PR, nor has it grown enough or spread to be PD.
The text adds a little nuance about certain types of tumor sites being hard to measure.
Yes. It notes that some sites, like lesions that are purely in the bone without a soft tissue component or diffuse infiltrates in the lung, are often considered unmeasurable or non-target lesions by these standard criteria when assessing for a partial response. However, documenting a complete response in these areas might still require a biopsy to prove the absence of active disease.
And for blood cancers, Hematopoietic cancers like leukemia, the assessment of response is different.
Right, because they're often disseminated and not forming discrete, measurable lumps. Beyond just looking at the morphology of cells in the bone marrow under a microscope, the text highlights the use of more sensitive techniques like flow cytometry and genetic assays like PCR to detect minimal residual disease, MRD. MRD refers to very low levels of cancer cells that are completely undetectable by standard light microscopy, but can be picked up by these more sensitive tests. Achieving MRD negativity, meaning fewer than, say, 1 in 10,000 cells detected are cancerous, is generally associated with much more durable remissions and better long-term outcomes. The text notes that strategies are being developed to try and deepen the response in patients who remain MRD positive, aiming to improve their chances of long-term cure. It really pushes the definition of complete response to a much deeper molecular level.
That's fascinating. The text also briefly touches on the use of tumor markers in assessing response.
Yes, tumor markers are substances, often proteins, that can be produced either by the tumor itself or by the body in response to the tumor's presence. They can often be measured in the blood, urine, or other body fluids. While they're often not specific enough on their own to diagnose cancer reliably, the text explains that if a particular tumor marker is known to be elevated in a patient with a confirmed cancer, then tracking the levels of that marker over time, watching it rise or fall, can serve as a useful, non-invasive indicator of changes in the overall tumor burden and how the cancer is responding to treatment. Table 69-6 gives examples like PSA for prostate cancer or CEA for certain adenocarcinomas.
And that same table, Table 69-6, also nicely illustrates why these markers often aren't great for initial diagnosis on their own, right? It lists non-cancer conditions that can also cause them to be elevated.
Exactly. PSA, for example, can be elevated in benign conditions like prostatitis or BPH, benign prostatic hypertrophy, not just prostate cancer. CEA can be elevated in things like pancreatitis, hepatitis, or even just in people who smoke. So they are tools best used for monitoring known cancer or perhaps in very specific screening contexts for individuals known to be at very high risk, not generally for screening the whole population or making a diagnosis from scratch.
Okay, that makes sense. Now let's dive deeper into some of those specific supportive care challenges that the text details. Pain management is clearly a massive one.
It is, and sadly, it's incredibly prevalent. The text cites figures suggesting that pain affects somewhere between 25% and 50% of patients, even at the time of their initial diagnosis. That number rises to about 33% for patients undergoing active treatment, and tragically, up to 75% of patients with progressive advanced disease experience significant pain.
75% with advanced disease. That's a huge number of people suffering. What are the main causes of cancer pain, according to the text?
The majority, about 70% of cancer pain, is directly related to the tumor itself. This can be due to the tumor invading or pressing on bone, nerves, blood vessels, or sensitive membranes. It can also be caused by the tumor obstructing hollow organs like the bowel or ducts like bile ducts. Around 20% of pain is estimated to be treatment-related. This can stem from surgery, postoperative pain, radiation injury, causing things like mucositis, painful inflammation of mucous membranes, enteritis, inflammation of the bowel, or damaged nerve plexuses or the spinal cord, or chemotherapy injury, causing mucositis, peripheral neuropathy nerve pain, or phlebitis vein inflammation. And then about 10% of pain experienced by cancer patients is actually unrelated to either the cancer or its treatment. It might be arthritis or back pain from other causes, for example.
So given those diverse causes, assessing the pain properly sounds like it needs to be really thorough and systematic.
It absolutely does. The text describes a methodical assessment process. It involves taking a detailed history, asking about the pain's location, its character, sharp, dull, burning, its intensity, often using a 0 to 10 scale or a visual analog scale, its temporal features, when does it occur, how long does it last, and any factors that make it better or worse. You also need to review the patient's full oncologic history, their past medical history, their social history, and perform a thorough physical exam focused on neurological and musculoskeletal systems. And crucially, the text emphasizes that pain needs to be reassessed frequently, because it can change, sometimes rapidly, as the disease or treatment progresses.
And there's a very important principle the text states regarding starting pain therapy.
Yes, a really critical principle. Pain therapy should not be withheld while the underlying cause of the pain is still being investigated. While finding the cause is obviously important for potentially targeting treatment, providing prompt and adequate symptom relief is paramount. The primary management tools are pharmacologic pain medications, and the text states that this approach is effective for the vast majority of patients, around 85%. For the remaining 12% or so, where medications alone aren't enough or cause intolerable side effects, other modalities are used. These can include specific anti-tumor therapy aimed at relieving the source of the pain, like palliative surgery or radiation to shrink a painful tumor, using radioisotopes that target bone pain, employing neurostimulatory techniques like 10S units, regional analgesia like nerve blocks, or sometimes even neuroablative procedures destroying specific nerves.
The text's overall conclusion on pain management seems quite definitive, almost optimistic.
It is. Surprisingly so, perhaps. It concludes by stating that very few patients will have inadequate pain relief if appropriate measures are taken. This strongly implies that with the right assessment, the right tools, and a proactive approach, effective pain management is actually an achievable goal for almost all cancer patients. That's a powerful message.
Okay, moving to another major supportive care challenge detailed in the text. Nausea and emesis vomiting. Most commonly caused by chemotherapy, right?
Yes, usually chemotherapy is the culprit, and its severity is often quite predictable based on which specific chemotherapy drugs are being used. Some drugs are highly immunogenic, likely to cause vomiting, others moderately, others low risk. The text describes 3 distinct forms of chemo-induced nausea and vomiting based on when they occur relative to the treatment administration.
Okay, what's the first one? Acute emesis.
Acute emesis occurs within the first 24 hours after the chemotherapy is given. This is the most common form.
Then there's delayed emesis.
Yes. Delayed emesis occurs later, typically 1 to 7 days after the treatment. The text notes this is less common overall, but can specifically follow the administration of certain drugs, particularly cisplatin, which is known for causing delayed nausea and vomiting.
And the third type sounds really interesting. Anticipatory emesis.
It is fascinating from a psychological perspective. Anticipatory emesis is actually a conditioned response. It happens before the treatment even begins, triggered by stimuli that the patient has previously associated with getting chemotherapy, things like the smell of the hospital or clinic, seeing the nurse, even just thinking about the treatment.
The text delves into the mechanism behind acute emesis, saying it's the best understood.
Yes. It explains that various stimuli can activate the vomiting center, which is located in the medulla in the brainstem. These stimuli can come from the chemoreceptor trigger zone, CTZ, in the brain, which detects toxins in the blood directly from the cerebral cortex, triggered by anxiety or anticipation, or from the intestinal tract itself, due to irritation by chemo. Multiple different types of neurotransmitter receptors are involved in signaling within this vomiting pathway, including dopamine receptors, serotonin, specifically 5-HT3 receptors, histamine receptors, opioid receptors, and acetylcholine receptors.
And understanding those mechanisms and receptors directly points to the types of drugs that are effective in blocking nausea and vomiting.
Exactly. By targeting these receptors, we can block the signals. The text lists several classes of highly effective antiemetic drugs. The serotonin receptor antagonists, drugs like ondansetron, granisetron, polonosatron, were a major breakthrough and are very potent, especially against acute emesis. More recently, the neurokinin-1 NK1 receptor antagonist drugs like aprepitant and fosaprepitant have also been highlighted as highly effective, particularly when combined with other agents for preventing nausea and vomiting from the most highly immunogenic chemotherapy regimens.
So how is the antiemetic therapy tailored based on the specific chemotherapy agent being used?
Low risk levels, right. It's risk stratified. For chemotherapy agents that have only a mild to moderate potential for causing emesis, the text suggests that simpler agents might suffice. Examples given are prochlorperazine, which can be given orally or as a suppository, or the steroid dexamethasone, often given intravenously. Giving these before the chemotherapy infusion starts can enhance their efficacy. However, for agents that are known to be highly immunogenic, the text lists cisplatin, mechlorothamine, dacarbazine, and streptozocin as examples more aggressive prevention is needed. The text stresses that combinations of drugs work best in this setting, and importantly, they should be started before the chemotherapy, sometimes 6 to 24 hours before. The text gives an example of a common, highly effective combination regimen, using a serotonin receptor antagonist like ondansetron together with dexamethasone. It also notes that adding an oral NK1 receptor antagonist, like aprepitant, to this combination can further reduce the risk of both acute and delayed vomiting, especially with highly immunogenic chemo like cisplatin.
The text offers a key principle about managing emesis, which sounds similar to the approach for pain.
Yes, the insight is powerful. Like pain, emesis is easier to prevent than to alleviate. This principle really drives the strategy of giving antiemetic medications proactively, especially before highly immunogenic chemotherapy, rather than waiting for nausea to start and then trying to treat it. Prevention is key.
What about managing delayed emesis, the type that happens days later?
This form, occurring maybe days 2 through 7 after chemo, might be related more to inflammation occurring in the bowel caused by the chemotherapy drugs. The text suggests can often be controlled with oral dexamethasone or with oral metoclopramide. Metoclopramide primarily acts as a dopamine antagonist, but at higher doses it can also block serotonin receptors, giving it broader antiemetic activity.
And that really challenging one, anticipatory emesis, the learned response.
This is tough because it's psychological conditioning. The text says the best strategy is actually prevention. That means rigorously controlling nausea and vomiting during the very first cycles of chemotherapy. If you can prevent the patient from having a bad experience early on, you might prevent them from developing that conditioned association between the treatment setting and feeling sick. If anticipatory emesis does develop, the text suggests trying prophylactic antiemetics given the day before the scheduled treatment might help. It also briefly mentions that experimental behavioral modification techniques have been studied for this difficult problem.
Okay. Another supportive care issue the text addresses is the management of effusions. That's abnormal fluid accumulation in body cavities.
Right. This can occur in the pleural cavity, which is the space around the lungs, a pleural effusion, in the pericardial sac around the heart, a pericardial effusion, or in the peritoneal cavity in the abdomen, which is called ascites. The text notes that if these effusions are small and not causing any symptoms, they might not actually require specific treatment. However, symptomatic effusions, especially those that aren't responding to systemic cancer therapy, like chemo shrinking the tumor causing the fluid, often do require local treatment to relieve the pressure and symptoms. This is particularly considered for patients who are expected to live for a reasonable period, perhaps longer than 6 months.
Let's start with pleural effusions, fluid around the lungs.
Okay. This fluid may or may not actually contain malignant cancer cells. When it does contain cancer cells, which accounts for about 75% of malignant pleural effusions, the most common underlying cancers causing it are lung cancer, breast cancer, and lymphomas. Characteristically, these malignant effusions are exudative. That means when you analyze the fluid, it has high levels of protein and an enzyme called LDH, lactate dehydrogenase, compared to the levels in the patient's blood serum. This helps distinguish it from other causes of fluid buildup.
So how are symptomatic malignant pleural effusions typically managed, according to the text?
The first step for providing symptom relief is usually thoracentesis, that's inserting a needle into the chest cavity and draining off the fluid. However, the text notes that the relief from just a single thoracentesis often doesn't last very long, typically less than a month, as the fluid tends to reaccumulate. So if the symptoms come back quickly, so within about 2 weeks, the text indicates that chest tube drainage is often the next step. It provides a fairly detailed description of the procedure. A chest tube, a larger tube than a needle, is inserted, and the fluid is drained until the output rate becomes consistently low, maybe less than 100 milliliters, over a 24-hour period. At that point, a sclerosant is often infused through the chest tube. A sclerosant is a substance designed to deliberately create inflammation and scarring within the pleural space, essentially trying to stick the 2 layers of the pleura, lining of the lung and chest wall, together to prevent fluid from accumulating between them again.
What kinds of sclerosants does the text mention being used?
Bleomycin, a chemotherapy drug, or doxycycline, an antibiotic, are mentioned as common choices. After infusing the sclerosant, the chest tube is usually clamped for a period, maybe an hour or 2, and the patient might be rotated into different positions, like on their back, front, and sides for 15 minutes each, to try and ensure the substance coats all the surfaces of the pleural space. After the clamping period, the tube is unclamped, and suction or gravity drainage continues. If the fluid output then remains low, again maybe 100 mello 24-Och, the chest tube can usually be removed, and a follow-up chest x-ray is taken the next day to check for reaccumulation. If a high rate of fluid drainage persists even after the first attempt, the text suggests repeating the sclerosis procedure. It notes that bleomycin might potentially be more effective, but is also more expensive, so doxycycline is often used as the first choice. If neither of those works, talc, another substance that causes intense inflammation, can also be used as a sclerosant.
Okay. How about pericardial effusions, fluid around the heart?
Symptomatic pericardial effusions, fluid buildup causing pressure on the heart, are often treated surgically if the patient is fit enough. Procedures mentioned include creating a pericardial window, an opening made surgically to allow the fluid to drain out into the chest cavity, or even pericardial stripping, removing part or all of the pericardial sac. If surgery isn't a viable option for the patient, the text says an attempt at sclerosis, similar to pleural effusions, can be made, possibly using doxycycline or bleomycin instilled into the pericardial space via a catheter.
And malignant ascites the fluid buildup in the abdomen. How is that typically handled?
This is often managed, according to the text, with repeated paracentesis. That involves inserting a needle into the abdominal cavity to drain off the fluid. Usually, small volume drains are done repeatedly as needed for symptom relief, rather than trying to drain huge amounts at once. If the ascites isn't responding to systemic therapy and requires very frequent drainage, the text mentions that peritoneovenous shunts may sometimes be inserted. These are surgically placed tubes that create a pathway to drain the acidic fluid from the abdominal cavity directly into a large vein, like the superior vena cava. However, the source also notes potential complications associated with these shunts, including occlusion, the shunt getting blocked, leakage of fluid around the shunt, and potentially fluid overload if too much fluid shifts into the bloodstream too quickly. It also mentions DIC, disseminated intravascular coagulation, a serious clotting disorder, as a possible complication, particularly in patients who also have severe underlying liver disease. Interestingly, the text notes the historical fear that inserting these shunts might potentially help spread tumor cells through the bloodstream, but it states that widespread metastases resulting directly from shunt insertion seem to be unusual in practice.
All right. Nutrition is another area described as complex and often really challenging in cancer care.
It absolutely is. The text highlights that both the cancer itself and the side effects of its treatments frequently lead to decreased nutrient intake. This, combined with metabolic changes caused by the cancer, can result in significant weight loss and profound alterations in the body's metabolism. This whole state is often referred to as cancer cachexia. While the text says it's difficult to estimate the precise prevalence, it states that most patients with advanced cancer experience some degree of weight loss and decreased appetite.
And the text gets into the causes of this cachexia, noting it's not just simple starvation from not eating enough, right?
Correct. Cachexia is described as a complex metabolic syndrome. It's understood to be driven by a combination of factors produced by the tumor itself. The text mentions examples like bomycin, or ACTH, and also by factors produced by the host's own body in response to the cancer, particularly inflammatory cytokines like tumor necrosis factor, TNF, interleukin-1, IL-1, and interleukin-6, IL-6. Altered growth hormone metabolism may also play a role. These factors collectively create this vicious cycle characterized by increased catabolism, the breakdown of body tissues, especially muscle, glucose intolerance, difficulty using sugar for energy, and lipolysis, the breakdown of fat stores. And crucially, the text makes the point that this underlying catabolic state cannot typically be reversed simply by providing the patient with more calories. Feeding them more doesn't necessarily stop the wasting process.
That sounds like a huge challenge for intervention then.
It is, and the text acknowledges that there is ongoing controversy and uncertainty surrounding exactly how best assess nutritional status in these patients, and, perhaps more importantly, when and how to intervene most effectively. Efforts have been made to develop objective assessment tools, and the text mentions things like a prognostic nutritional index, which might incorporate factors like serum albumin levels, triceps skin fold thickness, a measure of fat stores, serum transferrin levels, and delayed hypersensitivity skin testing as a marker of immune function related to nutritional status.
Are there any simpler thresholds mentioned that might trigger consideration of intervention?
Yes. The text notes that some clinicians might consider intervention when a patient meets certain criteria, such as having less than 10% unexplained weight loss over a period, a serum transferrin level below 1,500 milligl, and or a serum albumin level below 34 gl. These are just potential indicators, though.
The decision about nutritional support seems particularly important because the text links malnutrition directly to how well patients tolerate treatment.
It does. It states quite clearly that cancer therapy appears to be substantially more toxic and less effective in the face of malnutrition. This really highlights the critical need to pay attention to and address nutritional status, even if the optimal way to intervene is still an area of active research.
But there's still that big question hanging over it. Does nutritional intervention actually change the course of the cancer itself?
Yes, the text is upfront about that. It states that it remains unclear whether nutritional intervention can actually alter the natural history of the cancer. However, supporting the patient's nutritional status is still considered a key component of overall supportive care, aimed at improving their tolerance to therapy and minimizing toxicity and hopefully improving their quality of life. If nutritional support is deemed necessary, and if the patient's gastrointestinal tract is functioning, the preferred method is always enteral nutrition, meaning using the gut, either through encouraging oral intake or by using a feeding tube rather than resorting to parenteral nutrition, which is intravenous feeding.
And the text adds a note of caution, even about using feeding tubes.
Indeed. It points out that the potential risks, burdens, and discomfort associated with placing and maintaining a feeding tube must always be carefully weighed against the likely benefits for that individual patient, especially in those with very advanced disease where the potential benefits might be quite limited. Pharmacologic interventions are also mentioned briefly. Magistral acetate, which is a progestational agent, is noted as being advocated by some clinicians for its potential to improve appetite and nutritional status in cancer patients, although its effects can be variable. The text ends this section expressing hope that ongoing research into understanding the complex cytokine-mediated mechanisms driving cachexia might eventually lead to more targeted and effective therapeutic tools in the future.
Okay. Now, stepping back a bit from the purely physical aspects, the text moves into the realm of psychosocial support. This seems like a hugely important, but maybe a less tangible, more complex area.
Absolutely. And the needs here vary enormously depending on the patient's individual circumstances, their personality, their support system, and where they are in their whole cancer journey. For patients who are undergoing active treatment, the text highlights common emotional responses like intense fear, anxiety, feelings of helplessness, sometimes anger, and often depression.
There's also a significant impact on self-image mentioned.
Definitely. The physical changes that often accompany cancer and its treatment, things like losing hair from chemo, significant weight changes, gain or loss, disfigurement from surgery, or even just the functional impact of needing help with daily tasks, can dramatically affect how a patient sees themselves and feels about their body. The text makes a nice point that practical advice and support focused on helping patients manage these changes, like coping with hair loss, can actually contribute significantly to them feeling better overall. Patients also grapple with a profound sense of loss of control over their bodies, loss of control over their time as treatment schedules dictate their lives, and the stress of trying to juggle work, family responsibilities, and the demanding requirements of treatment is just immense.
And the text specifically calls out sexual dysfunction as well.
Yes. It notes that this is highly prevalent among cancer patients and survivors, affecting intimacy in relationships. It emphasizes that this is a topic that requires open and sensitive discussion between the healthcare team and the patient, even though it can often feel awkward or difficult for both sides to bring up. The text stresses the vital role of an empathetic, multidisciplinary team. Here, a team that is sensitive to the individual patient's psychosocial needs and is willing to engage in negotiation and support where possible without compromising the medical effectiveness of the treatment plan.
And importantly, the challenges don't necessarily end when active treatment finishes, even for those who are considered cured or in long-term remission. The text discusses the distinct psychosocial difficulties faced by cancer survivors.
This is a really important area. Survivors enter a different phase with its own unique set of issues. There's often fear associated with stopping active treatment, as many patients come to link the ongoing treatment with their continued survival. Letting go of that safety net can be scary. And perhaps the most pervasive and threatening concern mentioned specifically by the text is the fear of relapse, the constant nagging worry that the cancer will come back. The text refers to this using the powerful term the Damocles syndrome, which really captures that feeling of living under a constant invisible threat.
Survivors also often have to adjust to long-term physical changes or handicaps resulting from their treatment.
Yes, both real physical limitations or changes and sometimes perceived ones. They might become overly preoccupied with minor aches or pains, constantly worried that they signal a recurrence. They can also face significant social and work-related difficulties. The text mentions things like a perceived decline in job mobility, sometimes being viewed by employers as less desirable workers, and even facing outright job discrimination or difficulties getting insurance. Reintegrating back into their normal life from before cancer can be surprisingly challenging for many.
And the text even mentions complex feelings like survivor's guilt.
Yes, guilt for having survived when others didn't, and also a persistent sense of vulnerability, feeling more susceptible to future illnesses. All of these points really highlight that comprehensive psychosocial support is needed across the entire cancer continuum during diagnosis, treatment, and long into survivorship. It's not just about the acute phase.
Finally, the chapter moves into the incredibly sensitive but necessary topic of death and dying in patients with cancer.
It addresses this directly. It starts by outlining the common physiological causes of death in cancer patients. Often, it's complications like a severe infection leading to circulatory failure, sepsis, or failure of major organ systems like respiratory failure, hepatic liver failure, or renal kidney failure.
Are other mechanisms mentioned as well?
Yes, things like intestinal blockage leading eventually to inanition, severe malnutrition and starvation, or advanced central nervous system disease causing complications like seizures, coma, or central hypoventilation where the brain's control over breathing becomes impaired. Dyspnea, the sensation of shortness of breath, is noted as being very common, affecting about 70% of patients in the preterminal phase.
Beyond the physical mechanisms, the text notes the profound psychological impact that the possibility of death has, often over a long period, from diagnosis onwards.
Yes, it emphasizes that from the moment of diagnosis, even if death is years away, the patient is severely affected by that possibility. The text describes a typical trajectory or phases that patients might go through when treatment is ultimately unsuccessful, reflecting their psychological journey.
What are those phases described in the text?
First, there's often an initial period of optimism, hoping for a cure. Then, if or when the tumor recurs or proves resistant to curative treatment, there tends to be an acknowledgement that the disease is incurable. At this point, the goal typically shifts towards palliative therapy, and the hope changes maybe to hoping for a long period of living with the disease, maintaining good quality of life. Finally, there often comes a time when the disclosure of imminent death occurs, either explicitly or implicitly, and this triggers yet another significant adjustment phase for both the patient and their family.
The text mentions those well-known patient adjustment stages, often discussed in this context: denial, anger, bargaining.
Yes, it lists the stages often attributed to Elizabeth Kubler-Ross: denial, isolation, anger, bargaining, depression, acceptance, and hope. However, the text is very careful to make an important point. Patients don't necessarily progress through all of these stages, nor do they do so in a neat linear order or at the same pace. People's responses are highly individual. Understanding where the patient is emotionally, how they are affected by their situation, and how they are coping is highlighted as a really important management goal for the entire healthcare team.
Communication is obviously absolutely critical here and undoubtedly very difficult for everyone involved.
It is. The text emphasizes that it is generally best to speak frankly with the patient and family about the likely course of the illness, even though these are hard conversations. It acknowledges that this is difficult even for experienced physicians to do well. The critical features of this difficult interaction, according to the text, are first, reassuring the patient and their family that everything possible for comfort will be done, and second, and perhaps most importantly, conveying that they will not be abandoned by the medical team as they approach the end of life.
That sense of not being abandoned, that feels incredibly fundamental.
It's absolutely paramount. The text also notes that, when asked, many patients express a preference for receiving end-of-life care at home or perhaps in a dedicated hospice setting rather than dying in an acute care hospital if circumstances allow. It even references a resource book, Home Care Guide for Cancer, suggesting it can be helpful for families managing care in the home setting. The overall goal of good end-of-life care, as presented, is to provide the necessary medical care seamlessly integrated with psychological and spiritual support, specifically aiming to prevent the sense of isolation and depersonalization that can sometimes accompany a death in a busy hospital environment.
The text also takes a moment to acknowledge the significant emotional toll that caring for dying patients takes on the healthcare professionals themselves, particularly physicians.
Yes, it explicitly mentions the issue of physician burnout in this context. It describes a syndrome characterized by fatigue, emotional exhaustion, a sense of disengagement from patients and colleagues, and a loss of personal fulfillment in their work. The text suggests that combating burnout requires conscious effort towards stress reduction, maintaining a balanced life outside of work, and setting realistic goals within the inherently challenging environment of oncology.
And finally, the chapter touches on the practicalities of end-of-life decisions.
This can be particularly challenging when the transition from curative goals to purely palliative goals isn't a smooth, planned process. Sometimes it happens abruptly due to a serious treatment complication or unexpectedly rapid disease progression. The text states a key default assumption here. Vigorous medical support for any potentially reversible issues is assumed to be desired and will be provided unless documented otherwise by the patient through advanced care planning.
Which really underscores the importance of having those proactive conversations about preferences, doesn't it?
Absolutely. The text emphasizes that the patient's wishes regarding life-sustaining treatments, things like CPR, mechanical ventilation, artificial nutrition, and hydration, must be discussed and elicited before the patient enters the terminal phase, ideally, while they still have the capacity to make these decisions. And these wishes should be reviewed periodically as the patient's condition and prognosis evolve. It points to the use of advanced directives, like living wills or durable power of attorney for healthcare, as the formal mechanisms for documenting these wishes, and mentions organizations like AARP and Choice in Dying as resources for information on these legal tools.
And the text briefly acknowledges the very complex and often controversial issue of physician-assisted dying.
Yes, it notes that this practice is legally permitted in some states. It describes the process, where available, as ethically and medically challenging. It requires things like candid discussion, ensuring clear, informed consent from a competent patient, often involving mandatory waiting periods and second medical opinions, and always requiring meticulous documentation. The text wisely directs the reader to another chapter, chapter 12 in the source, for a more complete discussion of the complex ethical considerations involved.
It's clear that navigating the end of life in cancer care involves this intricate mix of medical, psychological, ethical, and legal considerations. And it really highlights the need for open, honest, and ideally early conversations about patient values and preferences. #tag looking ahead.
So we've just completed this really intensive deep dive into the comprehensive clinical approach to the patient with cancer, as Chapter 69 lays it all out. As this chapter concludes, the text naturally performs a transition, connecting the immense burden of the disease we've just discussed back to the possibilities of prevention and early detection.
Yeah, it makes sense. It highlights that really understanding the disease process itself, how cancer develops and progresses, inevitably leads you to think about how we might stop it from occurring in the first place, or at least catch it at its very earliest, most curable stages.
Exactly. And the overall goals of prevention and early detection, as they're briefly mentioned in the introduction to the next section of the text, are ultimately about reducing cancer mortality. You do that either by preventing the cancer from ever developing in people who are at risk, or by effectively screening populations to find existing cancers much earlier than they would otherwise be found.
The concept of carcinogenesis itself is briefly defined here too, setting the stage for prevention talk.
Yes, the text describes carcinogenesis, the process of cancer development, as typically being a multi-year, multi-step process. It involves an accumulation of changes within cells that eventually result in the aberrant, uncontrolled growth processes we recognize as cancer. Prevention, therefore, is framed as involving the identification and, where possible, the manipulation or mitigation of the various biological, environmental, social, and genetic factors that are known to contribute to this causal pathway.
And the importance of education and promoting healthy habits is highlighted as key strategies in this effort.
Absolutely. The text really emphasizes the crucial role of public education in raising awareness about risk factors, and it positions clinicians, doctors, nurses, other healthcare providers as powerful and credible messengers regarding these identifiable risks and the clear benefits of adopting healthy habits. Things like discussing the hazards of smoking, advocating for healthy lifestyles, and promoting the use of proven cancer screening methods during patient encounters are all highlighted as essential clinician activities.
And smoking cessation is presented, unsurprisingly perhaps, as a particularly strong and highly modifiable risk factor, maybe the most important one.
It's arguably the single most impactful area for cancer prevention. The text lists a truly staggering range of cancers that are strongly linked to smoking. Not just lung cancer, but also cancers of the larynx, voice box, oropharynx, throat, esophagus, kidney, bladder, colon, pancreas, uterus, cervix, and even acute myeloid leukemia, a type of blood cancer. It notes that while quitting smoking significantly lowers the risk over time, some of the genetic damage caused by smoking may be permanent, meaning the risk might not immediately drop all the way back down to that of a never smoker. Environmental tobacco smoke, secondhand smoke, is also clearly stated as being carcinogenic. Preventing tobacco use initiation, especially among young people, is framed as a crucial pediatric health issue given the young age at which most smokers start. The text also touches on the rising use and concerns surrounding e-cigarettes. The importance of counseling patients who currently smoke is stressed, with the text even noting that simple advice from a clinician can be effective in prompting quit attempts.
What kinds of approaches does the text mention for actually helping people quit smoking?
It discusses recognizing nicotine addiction as a chronic, relapsing condition. It mentions understanding the different stages of readiness to quit that a patient might be in, and it advocates for combining different strategies for the best results. These include counseling and behavioral therapies alongside pharmacologic aids. The text lists nicotine replacement therapies like patches, gum, lozenges, and prescription medications like bupropion and varenicline as effective aids. The text does touch on the ongoing controversy surrounding e-cigarettes. It acknowledges they're advocated by some as a cessation tool, but crucially emphasizes that their long-term health effects are still poorly studied, and the lack of manufacturing controls has led to serious lung injuries in some cases. It also reminds us that other forms of tobacco, like cigars and smokeless tobacco, chewing tobacco, snuff, also carry significant risks, including for oral and esophageal cancers as well as dental problems.
Okay, beyond smoking, physical activity is also listed as a modifiable factor linked to cancer risk.
Yes, the text states that regular physical activity is associated with a decreased risk of developing colon cancer and breast cancer. It does add a small note of caution, though, pointing out that in observational epidemiologic studies, it can sometimes be difficult to completely disentangle the effect of physical activity itself from other healthy lifestyle factors that tend to go along with it, potential confounding factors.
Right. And what about diet modification? That's often talked about.
The text addresses diet, stating that some epidemiologic studies have suggested a link between diets high in fat and an increased risk of certain cancers, including breast, colon, prostate, and endometrial cancers. However, it immediately adds a very critical caveat. Fat intake has not been proven to directly cause cancer, and studies looking at the relationship between dietary fat and cancer risk have actually produced conflicting and inconsistent results over the years. This really reflects the immense complexity of studying diet as an exposure. People eat complex patterns of foods, not single nutrients in isolation, and dietary habits are often tightly linked with other lifestyle factors, making it very hard to isolate the effect of one component like fat. Fiber intake is also mentioned, with the text noting it has been associated with a decreased risk of colon cancer in some, but not all, studies.
These points clearly show how understanding the burden and the potential causes of cancer, as we've detailed from this chapter, naturally leads into exploring these complex strategies for prevention. It sounds like a whole other massive area of research and public health effort in itself.
It certainly is. These points just provide a brief glimpse into that next frontier in the battle against cancer, trying to stop it before it even starts, or at least finding it when it's at its most vulnerable, earliest stages. Hashtag outro.
So we have just completed a really comprehensive, very deep dive into Chapter 69 of this core medical text, focusing entirely on the clinical approach to the patient with cancer. We've journeyed all the way from the stark global statistics and the intricacies of how incidence and mortality are even estimated here in the U.S., through understanding those complex layered determinants of prognosis, the tumor's anatomical stage, the patient's overall physiologic reserve via performance status, and the increasingly important biology of the tumor itself. We explored the critical decision-making around treatment, intent, curative versus palliative. We talked about the absolute necessity of multidisciplinary collaboration and the importance of adhering to evidence-based treatment protocols. And we spent significant time on those absolutely vital and often profoundly human aspects of supportive care, managing challenging complications like pain and nausea, addressing nutritional challenges like cachexia, providing psychosocial support throughout the journey, and navigating the incredibly sensitive territory of end-of-life care and decision-making.
Yeah, we really set out to master this chapter, didn't we? Aiming for that level of understanding you'd expect from elite professionals in the field. And by methodically unpacking each section piece by piece, I think we've gained a really solid foundational grasp of how science of oncology is actually applied in the complex reality of patient care. It's about integrating the stats, the biology, and always the patient's lived experience.
It's clear from this chapter that cancer care is just this dynamic, incredibly multifaceted endeavor. It's a constant interplay between cutting-edge scientific knowledge, some pretty challenging statistical realities, and the deeply personal journey of a human being facing a diagnosis that can change everything.
And truly understanding that delicate balance, that interplay, is absolutely key to providing genuinely comprehensive and compassionate care.
So as you, our listener, reflect on everything we pulled out of this chapter today, maybe consider this. The text reveals cancer not just as a collection of abnormal cells, but as a disease that, for the person experiencing it, can feel like a fundamental betrayal by their own body. We've dug into the numbers, the biological details, the clinical pathways, but woven through absolutely all of it is that profound, individual, personal journey. As we strive to master the medical facts and the technical approaches outlined here, how do we ensure that we equally master the empathy, the communication skills, and the comprehensive supportive care that are required at every single stage of that patient's journey, from the shock of diagnosis through treatment into survivorship, or perhaps towards the end of life?
Or perhaps you could ponder the text's emphasis on the increasing importance of tumor biology and patient performance status, alongside the traditional anatomical stage, in guiding treatment decisions today. Given the enormous heterogeneity, the text described the biological differences even within a single patient's tumor. How will our approach to cancer care continue to evolve and become even more personalized in the future? How will we continue to balance the most advanced molecular science with that fundamental human need for comfort, for support, and for clear, honest communication that we talked so much about today?
Thank you for joining us for this deep dive into Chapter 69.
We really hope this detailed exploration helps solidify your understanding of this incredibly critical and complex topic in medicine.